So we now move on with the third presentation, which is about response assessment in lymphoma. And I'm going to take you through some of the larger studies that have been done and basically positioning where we are and with a little bit of an outlook to the future. I have no disclosures with regard to this presentation. The pivotal questions when using imaging in response assessment is not, it has very little to do with the descriptive statistics about sensitivity and specificity. Let's say when we monitor response, the imaging should have an impact on the patient management, on patient outcome, quality of life, and obviously also preferably on limiting the costs of healthcare. Dr. Meyerhofer already described the FDG avidity of the various lymphoma subtypes in much more details. Here as a short reminder, the Hodgkin's lymphoma are virtually all FDG avid. The non-Hodgkin's lymphomas, you have to be careful, especially with frequent non-Hodgkin lymphoma subtypes like follicular and marginal zone, which may or may not be FDG avid. Let's say if they're FDG avid at baseline, you can use it for monitoring therapy. If not, you have to be aware that you need other imaging modalities. And as you can see here, there is quite a distinct difference between aggressive and indolent lymphoma. And in the top row, you see the high uptake in aggressive diffuse large B-cell lymphoma and the still positive but less striking FDG avidity in follicular lymphoma. And as Dr. Meyerhofer said, the closer the baseline FDG uptake gets to what is basically the organs of reference in response monitoring, the activity in the liver, the more difficult it gets to reliably use FDG for response assessment. So wrapping up what the assets of FDG-PET CT is obviously the sensitivity, picking up disease in normal sized nodes, excluding disease in enlarged but non-effective affected nodes, picking up the organ localizations and the bone marrow involvement, replacing biopsy in Hodgkin's disease and in diffuse large B-cell lymphoma. If you lump a large number of staging studies together, there is a reclassification of stage in approximately 20% of the patients, which is a pretty normal or rather average number of reclassifications that you will read in literature for many malignancy. And in particular in malignant lymphoma, there's more upstaging than downstaging. The early response assessment is what I'm going to talk about today. And obviously follow-up after end of treatment is an option when there are clinical reasons to detect a relapse early. So why do we want early response assessment? First of all, a substantial number of patients will not be cured by standard therapy. So a change or intensification or a combination of therapeutics might improve outcome. Second, late treatment-related morbidity and mortality, especially after combinations of chemotherapy and radiation, may drive the need for reduction of therapy in those patients who do not need the full amount of systemic and radiotherapy. So a second argument for early response assessment is to reduce therapy where you can do that without compromising outcome. And we have some beautiful phase 3 studies underpinning this. And obviously, we want to arrive at individualized patient management strategies, which are risk adapted and response adapted. Here you see the criteria that we use for assessing response in lymphoma, and these are relatively pragmatic. They were first devised at a meeting in France, in Deauville. On the picture on the lower right, you can see it was a really tough place to meet. And for reasons of simplicity and reproducibility, it was thought that rather than coming up with complicated quantitative scaling, using an internal reference of the FDG uptake in the background, the mediastinum, and the liver would be could be helpful in assessing response of lymphoma to treatment. And how does this look like? Here you see 5 different cases at staging on the top and response at the bottom row of the slide. And you can see that if the Deauville 1 score is attributed, there is no discernible uptake left in increased uptake at baseline. So this is a complete metabolic response. In Deauville 2, there is some markedly increased uptake at baseline in the left axilla, and a very faint lesion at follow-up. And this is also a complete metabolic response. Another patient with an axillary mass shows a little bit more uptake, so in the same ballpark as the uptake in the liver. And this is sort of the intermediate category, but generally this uptake is also considered response. However, if the remaining uptake is above the liver uptake, it becomes critical. This patient with an intensively FDG-avid lymphadenopathy in the neck has a remaining strongly FDG-avid lesion here in the right supraclavicular region. This is a Deauville 4, and this is not a complete response. This is judged as a partial response. And it can get worse that a patient with an intensely positive FDG-avid mass in the mediastinum has persisting uptake that is much higher than the liver. Say these are the patients where there is a partial response, but it's not sufficient in terms of predicting a favorable outcome. So how is this interpreted? Complete metabolic response scores 1, 2, and 3. Partial metabolic response score 4 and 5, with reduced uptake compared to baseline, and for bone marrow that the residual uptake is higher than normal bone marrow uptake, but reduced as compared to baseline. Bone marrow is difficult because the chemotherapy also induces changes in bone marrow uptake, so you have to be conscious of that. No metabolic response means that the Deauville score is 4 or 5, but also no significant change in the uptake from baseline. It can be at the interim, so during treatment or after completion of treatment. Progressive metabolic disease is a score of 4 or 5 with increased uptake from baseline and or new lesions consistent with lymphoma. Can also be scored at the interim or the end of treatment. So the take-home message is Deauville score 1 and 2 is negative. Deauville score 4 and 5 is positive. Deauville score 3 is sort of intermediate, but it usually indicates a good prognosis with standard treatment. So the clinical context is really relevant. If you're considering de-escalating treatment, say observing a Deauville 3 score at the interim is an argument not to do that. Conversely, let's say if you would consider increasing treatment, a Deauville score of 3 also is not very much underpinning the need to do that, given the good prognosis with the standard treatment. And if you consider a change in the therapy, moving to second-line therapy on the basis of imaging, it's always good to discuss in the multidisciplinary team and consider whether a verification biopsy is indicated, because there are false positive findings in the sense that inflammatory lesions may very well mimic lymphoma lesions, and it would not be appropriate to change therapy on the basis of a newly developed inflammatory lesion. So from another study, you see here the lesion in the mediastinum, very small lesion, uptake higher than the liver, positive by Deauville score, it's a 4. And here you have a lesion in the neck, and here in the groin and parailiac region with a score of 3, and that would be a negative scan. So this would be a metabolic remission. Pitfalls and caveats, there are many. There is obviously an impact of patient preparation, timing, and scanning protocols. You have to be very conscious of the fact that if you scan relatively early at baseline, so relatively early after injection, and then do your follow-up scan a lot later after injection, so with a longer interval between injection of FDG and scanning, this may and will affect biodistribution and may influence the FDG targeting to the tumors, and thus may falsely tempt you to read in favor or against response. So having your patient preparation, the timing and the scanning protocols adequately set up, reproducibly set up, is very important. Obviously, growth factors and bone marrow repopulation are no friends of FDG-PET CT restaging of the bone marrow, because expanding normal bone marrow will heavily take up FDG. We do see treatment-induced changes, for example, due to a thymic rebound during chemotherapy, but there are also other diseases that may mimic lymphoma. And for example, this patient who had an extensive tuberculosis infection that, say, if you wouldn't have known it, would could very much be confused with a malignant lymphoma. The next point I would like to make is that timing of the interim PET is crucial. First of all, the timing in relation to the treatment strategy. It's wise to plan the interim PET as close to the start of the next cycle as possible. Leave 2 weeks between the repeat PET scan and the administration of GCSF. And when you're doing end of therapy assessment, leave 3 months between the conclusion of radiotherapy and the follow-up PET scans. So when should we do the interim PET? You can do it very early after 1 cycle versus early after 2 or 3 cycles. The most compelling evidence that we have is that the interim PET after 2 cycles works for ABVD. It seems that the interim PET after 1 cycle yields a higher rate of positivity, which is logical because the patients only had 1 cycle of chemotherapy. It needs additional data what the meaning of such remaining activity is, whether we are more sensitive to picking up those patients who will ultimately fail therapy. So end of treatment imaging, it's prognostic for patient outcome, but it's considered less optimal um, because the switch from ABVD to more potent alternatives, for example, BIACOP or escalated BIACOP, can be given earlier on the basis of an interim scan. So rather than exposing the patient to a full cycle of first-line treatment, the interim PET suggests that we are able to indicate to the hematologist those patients who need more treatment. And there's a lot of literature on the use of PET in treatment response for lymphoma. This is a summary of some of the early work, which generally heterogeneous populations, in part retrospective, no PET-induced change in therapy. But this set the stage for the interest of thoroughly exploring what FDG-PET-CT could do to assess response. The de-escalation strategies are basically aiming at a decrease of the number of chemotherapy cycles, the option to omit the rather toxic chemotherapeutic bleomycin, or the option to switch to less potent chemotherapy in these patients who do well. There is a need for limiting or omitting radiotherapy, especially in young patients, in case there is not any benefit for irradiating the nodes in those patients who are cured by the systemic therapy. And there's obviously a need for patients who do not respond well, that we set criteria for escalating to more potent chemotherapy, identifying those patients who will benefit, but also identify when the switch should be made. And this is a very early study where gallium-67 was also still used. But if you look at the PET part of the study, what these authors did was that they treated patients with unfavorable, early unfavorable advanced Hodgkin's lymphoma. If they had a intermediate risk international prognostic score, they got standard treatment. If they had a high risk, they got intensified treatment. They did an early PET and then switched on the basis of PET if the PET was negative, independent of the baseline IPS score, to standard therapy if the PET was negative. And if the PET was positive, the patients went on with intensified treatment. And what they could show in this study was that it basically didn't matter in terms of event-free survival and overall survival, so that the early PET what could be considered the gatekeeper of how the patients could be treated best after the first two cycles. And this was taken further in the RAPID trial that was published a couple of years ago in the New England Journal, where it was shown that in the PET negative group, omitting radiotherapy basically didn't affect the progression-free survival or the overall survival, especially overall survival. With a very long follow-up of 10 years, you can see that there is basically no difference in the PET negative patients. Switching gears now to advanced Hodgkin's lymphoma, this was the study that sparked the interest here. Study by Gallamini, published in 2007 in the Journal of Clinical Oncology, basically observing that the PET after 2 cycles was more predictive for outcome than the international predictive score. So patients who had a high score but a negative PET did relatively well, but the patients with a low score and yet a positive PET did very poorly, as compared to the patients with a high score and a positive PET. So PET appeared to be more discriminating about towards outcome, and that was further confirmed in this study where the interim PET guided treatment intensification, and that basically showed that the patients in whom you do not intensify treatment indeed have a very good prognosis. The Rationale trial again in advanced Hodgkin's lymphoma used an interim PET after 2 cycles of ABVD. And very importantly, what could be shown is that the patients with a negative PET, you could safely omit bleomycin from the regimen. And these patients had a similar progression-free as well as overall survival. Conversely, the patients with positive PET at the interim did less well as expected, but with escalated with BCOP, they were managed after the interim PET was done, but it was also shown that escalated BCOP did not have an advantage over BCOP 14 regimen. So subsequently, there was a opinion paper written, and that said a change to the treatment paradigm is appropriate. An interim PET adapted treatment approach after 2 cycles of ABVD should become the standard of care for all patients. So that implicates that a positive PET after 2 cycles of ABVD requires a discussion whether the patient should be should be treated with BCOP or escalated BCOP. A negative interim PET in patients treated with ABVD considered the stop of bleomycin. Higher international prognostic score and more advanced stages, we have to be aware that the negative predictive value for ABVD may be the case. It's not the case for the interim PET when using escalated BCOP. In patients treated with escalated BCOP, if the interim PET is negative, 4 cycles are just as effective as 6 cycles in terms of outcome. And also the patients that at the interim PET still have a Deauville 5 score are at such a high risk of treatment failure that it is postulated that the switch from ABVD to escalated BCOP is not sufficient to induce a long-term remissions. So in non-Hodgkin lymphoma, it is more complicated. It may be an effective predictive biomarker, but it is not ubiquitously accepted as standard of care. It will happen most probably, though. Inconsistency in the timing of interim PET and the therapeutic regimen and PET reporting criteria do not make it easy to interpret the literature. In those patients with a metabolic complete response, in the diffuse large B-cell lymphomas, some 20% of the patients will relapse, but also almost all patients with follicular lymphoma will relapse. We have to be careful with false positives due to inflammation and tumor necrosis. Nevertheless, if you perform interim scanning, the interim PET is better than just CT to predict the prognosis and to exclude progression. However, changing of standard regimen on the interim PET is not yet recommended unless there is a clear evidence of progression. Looking at more fancy parameters beyond the visual scoring by Deauville, you can look at SUVs, or you can look at the metabolic tumor volume. And this is what this French group did. And they were able to show that if you look at the risk factor metabolic tumor volume, you see that the patients with a higher tumor load do worse, which is as expected. The patients who were negative at the end of therapy do better than the patients who are positive. And that is also obviously obvious. But what they also showed was that if you combine the two, say having one of the risk factors positive is just as good as having both of the risk factors positive. No risk factor is obviously the best indicator for a favorable outcome. Pseudo-progression was on immunotherapy was already addressed, and this is a significant issue. If you see new lesions, especially at the interim, or you see lesions becoming more intense on the interim scan, while others show less uptake, you have to be very conscious of the fact that immunotherapies like nivolumab, the PD-1 antibody, may induce the phenomenon of pseudo-progression. How do you deal with that? Well, it's not very straightforward, but there are ways of using subsequent imaging to confirm whether there is a real progression or not. So confirmation of progression via a subsequent scan to detect delayed responses, measuring new lesions to include them in the total tumor volume, accounting for durable stable disease as a benefit, and treating beyond conventional progression if the clinical situation allowed. And the previous speaker already showed very impressive data on what treatment beyond conventional progression actually means. So coming to my conclusions, I think it's fair to say that FDG-PET-CT provides important clinically relevant information before, during, and after treatment of malignant lymphoma. Malignant lymphoma is by far the most advanced field in oncology that utilizes PET-driven changes in systemic therapy of cancer. The solid tumors are not that far advanced as the use of PET in malignant lymphoma. The body of evidence is largest in Hodgkin's lymphoma, where we have large phase 3 trials generating the evidence that we need for appropriate introduction in clinical practice. And unfortunately, non-Hodgkin's lymphoma is still a rather scattered landscape. And we have, fortunately, ongoing clinical trials based on FDG-PET that will, in the near future, answer important clinical questions that have arisen and will be addressed in these clinical trials. So with that, I would like to thank you for your attention.